Good morning, clinical problem solvers. Good afternoon, good evening. It's Tuesday, it's Neurology Morning Report. Excited to see everyone. And you know the routine. We would love to have a case to be presented and two discussants to discuss that case, ideally one identifying as a woman and one identifying as a man. So do we have a case this morning? Kirtan has a case. It is going to be an amazing morning. All right, then quickly, two people volunteer because last time Kirtan presented a case, it was an hour and 45 minutes to discuss. Great. Two discussants. Mohammed, welcome back. All right. That's great to have Mohammed discussing, and then ideally someone identifying as a woman to discuss with Kirtan, Mohammed, and myself. Who would like to discuss with us? You might be thinking, oops, it's neurology. I don't want to discuss. Neurology is too difficult. That's a great reason to discuss. You'll learn something, you'll have fun. You might be thinking, English isn't my first language. I'm not sure I'm ready to discuss. I'm just listening. That's fine too. We have Spanish speakers and Portuguese speakers and speakers of many languages here. Those are my two lines. They never work. How else can I allay your fear and encourage you to join us? Even awkward silence doesn't seem to be working. Anyone like to discuss with Kirtan, Mohammed, and myself? Gabby is encouraging you. Gabby knows from firsthand experience as a discussant and presenter and scriber and teaching pointer, all roles have been. Anyone? Anyone? Anyone like to join in the fun? Tick tock, tick tock. The time is going by. Everyone's learning is being suspended until somebody volunteers. Nobody wants to volunteer for a neurology case? What does the easy Kirtan case mean? That is a fair question. Anne-Marie, is that you volunteering or? All right, we have some back and forth between Marie and Anne-Marie. You do it. No, you do it. You do it. No, you do it. All right, which one, Maria or Anne-Marie? Well, promise is getting in the game. Once you identify yourself, then you are also at high risk for being asked if you are so close to volunteering someone else. Why wouldn't you want to volunteer yourself? No problem, Anne-Marie, no worries. Maria or promise, after pushing Anne-Marie, I'm returning to you. Anyone? Anyone else who's joined? Since then, we're looking for one more discussant. Ideally, a discussant identifying as a woman. Promise and Maria are saying you first, no, you first. You first, no, you first. No one likes to be voluntold, that's fair. But Maria's getting a lot of encouragement. No pressure, Maria. Anyone like to volunteer? All right, Maria is saying, anyone else? Last chance. We know Maria loves neurology and discussing neurology cases so much, but she wants to give other people the chance. All right, knowing that Kirtan's case might take us past 10 o'clock, let's go ahead and, well, you're shaking your head, Kirtan, but we'll see. Great, why don't you introduce yourselves, Mohammed, Kirtan, Maria, and then we'll go ahead and get started. Thank you all for volunteering, and others, please think about volunteering next time. It's so much fun. Why don't you this time, while you're watching, and when you hear me ask questions to Mohammed and Maria, think, what would I answer? And you'll realize, oh, I would have said some of that. Yeah, I think I can do this next time, so that we can have a larger pool of volunteers. As much as we love our future neurologists, Mohammed and Maria, to volunteer almost every time, and Kirtan as well. Great to have other people learn as well. Okay, go ahead and introduce yourselves, and then we'll get going.
Hey guys, my name is Mohammed. I am a senior medical student at Al Faisal University in Riyadh, Saudi Arabia. Right now, I've been doing like a few rotations in the US prior to applying to neurology in September of this year. I haven't been really coming, so this might be tough for me. I haven't been discussing or seeing neurology cases a lot the past few months, but hopefully we'll do a good case together. I've been seeing like on Twitter the cases that Curtin always like posts. They're always like super tough. Let's see what we can do about this.
Awesome. Kirtan, Maria?
Yes, so good morning, everyone. I have a nice case today, and thanks for volunteering, everyone. And today I can see Gabby after a long time. So it's going to be amazing, her teaching point. So let's see how it goes.
Great. And Maria?
Hi, everybody. I'm really excited. I'm also into neurology. I'm from Guatemala, and I'm really scared, but let's do it.
Conquering her neurophobia, one Kirtan case at a time. All right. Kirtan, go ahead and give us just the chief concern, chief complaint in as few words as possible to get started.
Yes, so the chief complaint is bilateral lower extremity paresis.
Bilateral lower extremity paresis. Maria or Mohammed, feel free to take a stab at how you would start thinking about that presentation.
Go ahead, Maria.
No, I was going to say that. Okay. So with bilateral lower extremity weakness first, I think it's always, or paresis, determining if it's like not get confused by any medical terms and during the history. So somebody might say that, and then you're biased to believe it. So always do like a physical exam and make sure it's actual weakness and not ataxia or sensory or I don't know, a lot of other things, fatigue, for example. And then I think our two main buckets are always neuro versus non-neuro. And then with assuming it's neurology, we have to make sure, you know, the localizing features of it. So maybe if determining, you know, is it like a more muscular component, more nervous component? And if it's like muscular, thinking, you know, like proximal weakness, and thinking about like muscle and neuromuscular junction. If it's nerves, think about like peripheral neuropathy, spinal cord, and then to determine that, we can really use like upper versus lower motor neuron signs. And then I'd really stick with like spine and below, although we've mentioned before things in the brain that can cause bilateral weakness because of the homunculus. You know, we have the legs right at the middle, so things in like the middle of the brain can affect both right and left legs, and then things like ACA strokes are characteristic of them, or like meningiomas. So I think it's a really interesting CC, and then definitely the physical exam and all of the other signs are going to help us determine the localization, and then maybe Moha can talk about the timing, because I totally forgot about that.
No, you didn't forget. You were just telling us so much amazing information about the localization. So brilliant. I have nothing to add, but just to echo some things that you said. So obviously, as Maria said, we're always thinking about localization and time course in neurology. So what's the neuroanatomical localization? And then that plus the time course should get us pretty close to the differential diagnosis. So first branch point, true weakness or not, right? Presumably, unless this is a medical patient with a medical background, they're not saying I have lower extremity paresis. Maybe they're saying I'm having trouble walking or my legs feel weak. And so the question is, as Maria said, is it true weakness, or is this a problem with sensation or coordination or pain or a higher order gait disorder in the brain that's causing the patient to subjectively feel like the legs are weak, or are they truly weak, as in there's true muscular weakness? And even backing up before that, right, is this true neurologic weakness, or what some people call asthenia, just sort of the feeling of weakness? We all know when we're sick with the flu, or if you've had COVID, or with anemia, patients with anemia will feel weak, right? Or patients with cancer, chemotherapy, et cetera. But if you test their muscles, they actually have full strength. They just feel their whole body is weak, as we do when we have the flu or something like that. So presumably it's Tuesday, it's Kirtan, it's going to be neurology, right? But first, is this true weakness, true neurological weakness, or the subjective feeling of weakness? And once we're in the true weakness category, as Maria said, we're somewhere along the pathway from brain to muscle. So we're on those corticospinal tracts, which start in the precentral gyrus, the primary motor cortex, descend through the corona radiata, internal capsule, anterior midbrain, anterior pons, anterior medulla, cross at the cervical medullary junction, go down the lateral corticospinal tracts in the spinal cord, synapse on the anterior horns. Those anterior horns come out as ventral roots through plexuses to peripheral nerves to neuromuscular junctions to muscle. So Maria told us we could be anywhere, right, from head to toe, quite literally. But if we have just the legs, and we're going to find out, right, and really the arms are not involved, Maria said very astutely, this is probably spine or below, meaning the spinal cord, thoracic or below, if the arms are okay, the cauda equina, or something in the peripheral nervous system. And then the pearl that's come up so many times that it's not, that Maria now just rattles it off like a full-fledged neurology attending, that very rarely you could get bilateral lower extremity weakness from a brain lesion, because the leg areas of the homunculus, as she beautifully described, are right in the midline. So a parasagittal meningioma, or if it's sudden bilateral ACA stroke, some patients, the ACAs come from a common trunk called azygous ACA variant, then rarely you could get faked out imaging the spine and going over and over again looking for what's going on here, and it's actually a brain problem. So fantastic. But in principle, you hear bilateral lower extremity weakness and the arms and above the neck are fine. There's nothing else. You're thinking thoracic spine or below, meaning cord, cauda equina, nerves, nerve roots, nerves, neuromuscular junction, muscle. Okay, fantastic. Maria, Maria teed you up for talking about the time course. Do you want to talk about that, or anything else you're looking for in the history to try to help us narrow things down here? And then we'll hear more history and move forward.
Yeah, for sure. So whenever I hear like weakness, I always ask myself if there is sensory component along with it. I think that like helps me a lot in terms of localization, because not a lot of places will give you just pure weakness. So this is important regarding the history part. And the time course is also important because if we can remember like the hyperacute, acute, then subacute and chronic. I think one of the cases that we've discussed, and it's on the podcast now, was the patient who was presenting with weakness, the subacute, and then I remember what did it turn out to be? I think it was an MS lesion at the end, but it was in the upper spinal cord. So, and it was this sort of like subacute kind of weakness. So that's, if we're focusing on the spine for now, I think something that subacute is a slowly growing mass, or a slowly growing maybe a tuberculoma. If the patient also has fevers that could lead you towards thinking about abscesses, they have tenderness in the spinal cord, things like that in general, like more localizing signs to really hone in on the place, or like or where the lesion is. Hyperacute, it could always be like a stroke. Although I doubt that it would cause a bilateral weakness, because the if I remember correctly, the anterior spinal artery, actually, yeah, it could be bilateral, because the anterior spinal artery is just one and the posteriors are two. So it could be a stroke of the anterior spinal artery, and This, I think, rarely happens. I haven't really seen a lot of cases like this, even on VMR. That's for the hyperacute. For the acute, I guess maybe something like a vasculitis, or maybe if the patient had this episode before, it could be a transverse myelitis. Chronic. GBS, of course. We have to think Guillain-Barré syndrome. I've seen a few recently, like there was a case about a child who was presenting with quadriparesis, left more than right, and it was like at the end, it's an interesting case that we can like discuss later on. I'll keep it. I'm not gonna burn it. Otherwise, for the chronic, I think also a mass can cause a chronic type of weakness, especially if it has been progressing like over time. Like started like 4 instead of like and then 3 and then 2 and then 1. But yeah, this is where I'm at. I think more history is gonna help us a lot in terms of like localizing and thinking about the specific etiology.
Fantastic, Mohammed. Great. So yeah, Maria gave us the localization part of the time course, and on a first pass, barring very atypical cause of bilateral lower extremity weakness in the medial sort of midline cerebral hemispheres, or probably spine and below. And so Mohammed is thinking through time course. So what could be hyperacute in the spinal cord or spine in general, because we don't know if it's the cord yet. As you said, stroke of the spinal cord, not common, less than 1% of all strokes, but you can get a stroke of the spinal cord, usually related, this anterior spinal artery syndrome, usually related to aortic pathology, aortic dissection, aortic aneurysm, aortic surgery, et cetera, though can be spontaneous, rarely, just the embolism went there. If this turns out to look like a stroke, we can talk more about spinal infarct. Trauma, usually going to be obvious from the history, would also be in the hyperacute bucket. And then in the acute, so sort of fast but not sudden, you mentioned transverse myelitis. People are starting to take issue with this term because so transverse myelitis is meant to mean an inflammatory myelitis that's fully transverse, but not all inflammatory myelitides are inflammatory. And not all inflammatory myelitides are transverse, and not all transverse myelitis causes are inflammatory. So you could get this syndrome of a full thickness axial lesion of the spinal cord from an infection, for example. And actually the most common cause probably of transverse myelitis, quote unquote, inflammatory myelitis is MS, and those tiny lesions usually are not fully transverse. Whereas things like neuromyelitis optica tend to be more full thickness and longer. But inflammatory myelitides in general, if we're in the spine, as you mentioned, GBS would be another sort of acute but not sudden inflammatory condition that could cause bilateral lower extremity weakness as part of the ascending, right? And we just haven't gotten to the arms yet, and that would be a peripheral nerve problem there. And infections, right? So infectious myelitis, so viral is probably the most common, but things like epidural abscess, very rarely you can get intramedullary abscesses in the spinal cord, but viral myelitis, you can get all kinds of syndromes. You can get flaccid myelitis, for example, from West Nile virus, which causes the poliomyelitis, meaning the gray matter being involved, polio itself, though fortunately we don't see that very more. And then these enterovirus cases, if this turns out to be a child, I think it's D68 and D71 or something like this, can cause a flaccid. It's in the spinal cord, but it's the anterior horn, so it's not transverse, but it's an inflammatory or infectious myelitis. And then subacute, you mentioned we could get a neoplasm. So depending on the age of the patient, if it's an adult, we'd more commonly think about a metastasis to the spine rather than a primary malignancy of the spinal cord or structures surrounding it. But you can get meningiomas and schwannomas and neurofibromas and all kinds of tumors there. And then TB, a subacute infection, right? We've had a number of TB cases presenting in various ways. If Kirtan is presenting a local case that he saw in India where the prevalence of TB is high, probably one of the first things on your differential for subacute bilateral lower extremity weakness would be Pott's disease, right? And then chronic, the most common would be a structural problem in the spine, cervical spondylosis. We should get arms involved, although as Mohammed said, maybe there are sensory problems elsewhere and the patient is really mostly reporting the weakness in the leg. So spondylosis would be the most common. That can be subacute or chronic, depending on the patient and the types of abnormalities. And then very rarely there are degenerative spinal cord conditions, many of them inherited, things like hereditary spastic paraplegia, adrenomyeloneuropathy, and other, those are sort of the main inherited spinal cord etiologies. And then there are some infections that present with a chronic myelopathy. HTLV1, Vale presented us a case once that's a viral illness. Most viral myelitis, VZV, HSV, EBV, adenovirus, et cetera, are going to be acute. But there are chronic viral myelitis in HTLV1, and the vacuolar myelopathy seen with AIDS are chronic. So we put a lot of emphasis on the spine here. Hopefully we're on the right track, but this general principle of hyperacute vascular trauma, acute infectious inflammatory, subacute neoplastic with some infections bleeding over, and then chronic structural degenerative genetic or some infections, I think is still reasonable depending on where we localize. Great, fantastic start, Maria and Mohammed. And Kirtan, why don't you give us a few more words for the HPI, and then I leave it to your discretion if you want to fill in the past medical, et cetera, in the bottom corner as well.
Sure. Yes, so for the HPI part, we have a 40-year-old female who presented with the complaints of lower extremity paresis and occipital headache of 7 out of 10 severity since last 2 days. Weakness subsequently progressed to the point where she was unable to stand or walk unsupported. She first went to a local clinic where steroids were prescribed, presumably due to transverse myelitis. Due to the COVID pandemic, imaging studies were not being done at that time. But even after steroids, her paresis was not affected, so she was still being paralyzed. Weakness reached its peak earlier that morning when she was completely unable to move her legs, and she then came to our emergency department. As for the review of systems, she denies bowel or bladder incontinence, neck stiffness or neck pain, any vertigo, dizziness, tingling, paresthesias, preceding fever, weight loss, night sweats, cough, chest pain, rashes, headache, any preceding diarrhea or abdominal pain. So all of these were negative complaints. As for the past medical history and medications, she is on none of them, everything is normal. And as for the social history, she denies alcohol, tobacco, or illicit drug use, and she has no allergies. And Aaron, do you want any clarifications?
Yes, you read my mind or read my eyebrows. 2 clarifications. One is you said she had this headache, but then she denied headache on the review of systems. The headache was there and resolved, or the headache was persistent?
Yes. Oh, my mistake. Actually, I forgot to take out that part. She does have headache.
Still has headache. Okay. And then you might have said it, and there's just so much interesting detail. I might have missed it and it didn't make it into the scribing. What was the time course of the headache and inability to stand? Did one come first? Did one come second? Did they evolve together? And is this hours, days, weeks, months, years?
Yes. So actually the patient told me that it was both simultaneously and it was over last few days. So actually everything began in last 4 days. Then she went to clinic. So she went to clinic on second day after her weakness began, and she came to our clinic total in 4 days after her initial complaint.
Got it, I think. Okay, Mohammed, you're up.
I think I might have should have went first the past time and made Mary take this one.
These are always the gambles of morning report.
Yeah.
Again, it's always complicated when there's lots of different things, different strategies you could take. You could try to think of Venn diagrams, right, for all these different things, or you could just pick off one and take a look at it under the microscope a little bit and see how you would think about that and see what how other things might fit in.
Yeah. So to start with, the occipital headache is always interesting to me because it's one of the the red flags sometimes that I take because of press. But as far as I know is that press doesn't really, so what I know is that press is a posterior reversible encephalopathy syndrome. So as far as I know, sometimes it's not posterior, sometimes it's not reversible, and sometimes they don't really have encephalopathy. So it's a good thing to have in mind if she actually has hypertension, and which is a risk factor for press, and that's been causing her the headache, and then it's not really posterior, so it's affecting also the anterior lobes, but I don't see how this would not affect her sensory part. So I would stray away from that for a bit. Other things that I'm trying like as much as I can to tie in the headache with the weakness. It might be a difficult task, but I'll try my best. So I'm sorry, Kirtan, the inability to stand, it came along with the headache at the same time, right?
Yes, almost at the same time.
Okay. So let's see. I think maybe what I'm thinking of right now is the time course. So 4 days history is sort of like subacute, I would say, or the acute, not the subacute, not hyperacute, not subacute, so acute. I would say maybe she has, or she could have, a structural cause of this headache. Maybe something like, I'm not really sure. I'm going blank here. It's actually been a while.
Oh, you're doing great. Yeah.
Let's think.
So why don't you roll with that? You said you're trying to put the headache with the leg weakness, and you're thinking about a structural lesion. What type of structural lesion and where would you put it to give you a headache and leg weakness? If these are related and they're coming on so suddenly and together, it's hard not to think so, isn't it?
Yeah. So something that it's a bit of a far-fetched, but like the congenital causes of like the spina bifida and things like that, I think tugging on the spinal cord and causing like some weakness, as well as like a structural like pulling on the brain itself as well. I wonder if her headache is really occipital in nature. Oh, something that could just pop to my mind is a migraine. So there's a migraine with hemiplegic migraine. I'm not sure if there's one that's paraplegic. But if that's the case, then maybe if she has like history of headaches, that would be important if this is the first time for her to get it. If it hasn't been responding to steroids, so like her weakness and the headache, so that tips me over towards something that's maybe could be inflammatory and the steroids did not really help, or infectious and the steroids did not help, or structural cause and it didn't also help. But it tips me away from the inflammatory causes, so that vasculitis, myelitis, MS, I think would probably improve with a course of IV steroids. Otherwise, denies fever, so we're not really in the realm of the abscesses. Denies weight loss, so maybe not really metastatic or something like a malignant cause of the weakness. And denies bowel and bladder incontinence. So this is important. So now we're not talking about the Coda-Equina syndrome, because I think in Coda-Equina you get bowel and bladder incontinence. I'm not sure if it was the other one that or conus medullaris and Coda-Equina. I always mix them up. I'm not sure which was which.
Yeah. Great.
Yeah.
Yeah, great. I was just going to comment. Yeah, Coda-Equina and conus medullaris, I always mixed up also, and they're so close together anatomically. It's actually pretty rare to. It can be pretty hard to disambiguate them, and you're going to be imaging the spine if you have this, saddle anesthesia and all of this stuff. So that may be a little bit heretical, but yeah, Coda-Equina is the more common one. That's very good, right? We're all a little bit surprised when we heard headache as part of this, right? And you were trying to reckon with that. And you did a great job doing so, Mohammed, because we were all thinking spine, and we were waiting for back pain, right? And we are probably waiting for, though we hadn't mentioned it, bowel and bladder incontinence. If this is a myelopathy, we won't say itis yet, or a Coda-Equina syndrome, as Mohammed said, if we're in the spine compartment here, spinal cord or Coda-Equina, and it's bad enough to cause near complete paralysis of the lower extremities, we're probably going to get some bowel and bladder symptoms as well, aren't we? So that would be a little bit of a I wouldn't say red flag, but flag and eyebrow raised, right? That, wait a second, are we really in the spinal column here, right? Or not? And so that headache tells us, as you said, Mohammed, probably we're not. Something is happening upstairs in the skull, right? And is this one process that's causing a skull thing and a spine thing, or is this one process in the skull that, as Maria clued us into, could be near the midline and causing both a headache and bilateral lower extremity weakness from effects on the corticospinal tracts, on the homunculus medially? Or are we going to find on the exam that there is some arm weakness or facial weakness or something also, and the patient was just focused on the walking difficulty because that was the most prominent symptom? And sometimes we'll find a subtle pronator drift or some reflex changes in the arms that tell us actually the arms are involved, just not to a point that the patient is aware of that difficulty. So they were focused on the legs. So then what's going on, right? So if we have, one dot with two arrows, going to both brain and spine, could this be a brain and spine process together? So a meningomyelitis, right? And so what could do that? Tuberculosis, right? Could cause meningitis and Pott's disease at the same time, or can cause lots of different things in the spine. Actually, can cause spinal cord abscess, can cause spinal meningitis, can cause arachnoiditis affecting the cauda equina, probably bowel and bladder with that. You can get West Nile virus. Usually it's going to cause meningoencephalomyelitis. The patient's going to have confusion and what looks like a meningoencephalitis or encephalitis, and then flaccid paralysis with that. In my experience, usually asymmetric rather than symmetric, as we're hearing in this case. And you might say, oh, this patient doesn't have fever, as you said, Mohammed, so probably not infectious. Yeah, probably not arboviral infection. But if you have an abscess in the brain that's truly walled off, you don't always get systemic signs like fever because the abscess is sort of compartmentalized, and that's true in the spine. So usually epidural abscess, you're going to see fever, but true intramedullary or intraparenchymal abscess, you may not. And TB, right? We know that, I'm not sure the percentage, but a lot of patients have extrapulmonary TB without pulmonary TB. So the lack of bowel and bladder for me makes the spinal column, meaning cord or cauda equina, much less likely and puts us probably upstairs. And back to Mohammed's key question in this case, right? How are we getting a headache and bilateral lower extremity weakness if that's really all we have? And that, I think, brings us back to one of Maria's key first points, right? Do we have something around the midline of the brain that's causing headache because it's a structural lesion, increasing intracranial pressure and causing effects on the bilateral lower extremity areas? And then what is it? Well, as you said, Mohammed, we're in the acute category here, right? This is not hyperacute, this is not subacute, this is not chronic. So what's in that category? Infections, we talked about. Could there be an abscess? Could there be tuberculosis in the brain somehow affecting the bilateral leg areas of the homunculus? Inflammation. So another brain and spine disease together could be, we talked about this last week, right, Maria? Acute disseminated encephalomyelitis, usually in kids, an acute demyelinating post-infectious syndrome. I call it the central cousin of Guillain-Barré, right? It's, instead of demyelination in the peripheral nervous system, it's demyelination in the central nervous system, usually post-infectious or rarely post-vaccine in children. Usually they have confusion and other symptoms of what's going on in the brain, as well as myelitis. You mentioned PRESS. That's an interesting entity, as you said, and I say as well, it's called posterior reversible encephalopathy syndrome, but it's not always posterior reversible. It doesn't always cause an encephalopathy. But that's usually in the setting of hypertension. We don't hear a history of that here, but maybe it's undiagnosed. And we don't really know why it happens, but presumably some failure of autoregulation in the setting of hypertension, that you have a hypertensive encephalopathy, essentially with a biomarker there, and that's some edema, which is most commonly in the white matter at the sort of parieto-occipital junction, though can extend into the watershed areas. And there's case reports of everything. There's gray matter PRESS affecting the cerebellum. There's a recent, actually, series, maybe not that recent anymore, but in the last few years, of PRESS with spinal cord edema as well. So you could put all that together, other things that can cause that, tacrolimus, bortezomib, other immunosuppressants and chemotherapies. But probably a little less likely here, but a vascular thing that might not be sudden, but can still be acute. And then the other thing, Maria or Mohammed, what else is right at this midline here, running right across the midline?
Falx.
Say again?
Falx cerebri.
The falx, indeed. So a meningioma of the falx, although this is a little fast for that, and getting warmer for, guess what I'm thinking? What is in the falx right there at the midline?
The sinus, the superior sagittal sinus.
Superior sagittal sinus, right? So this is a vascular etiology that's not always sudden, but if the patient had a venous sinus thrombosis, that causes a headache evolving over days, usually. And if the patient then had bilateral hemorrhages or bilateral ischemia or bilateral edema, right around that superior sagittal sinus, you could get this central paraparesis, central paraplegia pattern that Maria saw without getting the bowel and bladder. So for me at this point after the history, I'm thinking we're up exclusively in the brain. And for that time course and with, I guess we're infectious, inflammatory, or this exception to vascular, a venous sinus thrombosis, I think is also on the list. Maybe this patient just got their AstraZeneca vaccine, although there are many more common causes of venous sinus thrombosis, and that complication is extremely rare with that vaccine. But if Kirtan's presenting us a current events type of case here. Okay, so Maria, you're going to comment on the exam after we hear it. I'm trusting you, Kirtan, that you said this won't go till 11, and so I'm spending a lot of time up front on the clinical reasoning, maybe at my or all of our peril, right, depending on who has meetings at 10 Pacific time. Maria, what are you most interested in going into the exam here? So we have our hypothesis testing when we hear the exam from Kirtan. What are you looking for, Maria, if you had to test one or two things before Kirtan? What is your antenna up for as he reads these things to say, ooh, that's really going to help us? Oh, I think Maria is frozen.
Yeah, I think so too.
Oh no. Maria, are you there? Hi. Did you hear me ask you a question?
I didn't hear like the last 2 minutes. I'm so sorry because.
No, you're fine. We saw you there smiling, and I thought you were smiling and thinking, but you were smiling and frozen. You were probably thinking also, but frozen. I was asking, we're going to ask you to comment on the exam. We haven't heard the exam yet. If you're listening to this exam, what things is your antenna up for, waiting to hear that are going to help us with localization and/or diagnosis? If you were going to pick out 1, 2, 3 things to listen for.
Yeah, so definitely first we started thinking spine and below, and then we got that not accurate with the headache. So definitely seeing like, is it really not in the spine, and do we have like any cranial nerve deficits, or I know he doesn't have like, she doesn't have like fever or night sweats, but as we've mentioned, infectious, I'd be thinking about like the next up, does she have any like meningismus, with that too? And then with like the bilateral lower leg weakness, definitely trying to figure out if it's upper or lower motor neuron, but it's so acute that even if we don't think we would have upper motor neuron signs in this moment, but definitely if they are there, they would be helpful localizing. If they're not, it's just not.
Oh, great, Maria. Yeah, so I think, sorry, you were cutting in and out a little bit. I think I got you. No, sorry. That's right. So you made another very subtle clinical point that obviously we're expecting upper motor neuron signs here, and that's going to help us confirm our hypothesis we're in the brain, or seeming less likely the spine, though not impossible, rather than the cauda equina or nerves where we would have lower motor neuron findings. But as Maria said, things that are really acute, the upper motor neuron signs take time to come out, right? They take time to emerge. Things like spasticity, even hyperreflexia can take some time. Often the Babinski sign, the upgoing toe, can be there from the beginning. That could be helpful. But as you said, if we didn't see anything, it doesn't exclude a central etiology here. And gee, with this headache, that sort of seems the most likely, such that even if we saw lower motor neuron signs, we'd still be thinking about a central etiology here. So I agree with you. I think the reflexes are going to be super important, even though we might not be able to bank on them. And the other thing for me is just going to make sure we really just have a problem only in the legs, right? Is there anything subtle in the arms? that tells us that we're, the idea that this is just a bilateral lower extremity process, which put us first in the spine and then at the midline of the brain, right? Or do we have to think a little more broadly? And is there anything above the neck, subtle facial weakness or anything like that would also maybe change a little bit how we think about the localization? And as Mohammed said earlier, are there sensory signs here? Is this really a pure motor problem? It means we're really somewhere along those corticospinal tracts, which would have meant for the spinal cord that we're either posterior and lateral exclusively at sort of 10 and 2 if you have the spinal cord anatomical view, or we're in the we have flaccid paralysis and we're in the anterior horns, or if there are sensory signs also, does that help us think about this? If all the sensory modalities are impaired, might not be that helpful in telling us. So I think we always do this exercise and we always end up saying basically we want the whole neuro exam. But I think being sure that this is upper or lower motor neuron will help us, with the caveat that Maria said that if this has been going on for months or years, the reflex hammer is going to be very helpful here. It's still helpful here, but maybe not as helpful as it would be in a subacute or chronic process. Okay, Kirtan, what was found on the exam here?
All right. So for the vitals part, everything was fine. The heart rate, blood pressure, oxygen, all good. The general examination was also good. No issues there. And in the neurological examination, for the mental status, patient was AO times 3, oriented to time, place, and person. For the cranial nerve examination, they were normal. The pupils were also round, reactive, and symmetric to light. As for the motor examination, the upper extremity examination was completely normal. And for the lower extremity examination, the power was 1 out of 5 in all the muscle groups. So all the flexors and extensor, it was 1 out of 5. As for the sensory examination, there was patchy loss of pain and temperature sensation up to the level of thighs, but no discrete sensory level was obtained. The vibration and proprioception was normal. As for the muscle bulk and tone, it was also normal. The reflexes were normal. So they were neither hyperactive, neither entirely absent. They were just there. As for the plantar reflexes, the plantars were downgoing bilaterally. So Babinski sign was negative. As for the meningeal signs, they were absent. So there was no evidence of neck rigidity, no Brudzinski or Kernick signs were present. The higher function evaluation was normal. And Aaron, if you don't mind, can I give you some labs because of the sake of timing?
Yeah, sure.
All right.
Unless I presume you're going to give me normal labs, which is fine.
No, I mean, I can even give you Csf findings, and then the imaging part in the next report, that will be more interesting. Yeah.
I see. Maybe hold off one moment. I know for timing, but let's just let Maria finish off the exam here if you're going to start giving us CSF and other things. I thought you were just going to tell us the serum labs are normal, and that's fine. But if you're going to give us more details, I understand now there are more than one aliquot left, but let's hear what you think of the exam, Maria.
I'm so confused, but yeah, at least we know that it's just like lower extremities, nothing like upper extremities, no cranial nerve deficits. And I'm thinking, like, going back to our original discussion, like, is the headache is their headache even real, or like, I don't know, because we are not having like anything that points towards the if we take out headache, I'd be thinking, like peripheral nervous system with like hyperreflexia and, weakness, maybe like GBS or similars. And then like maybe the headache can be something like viral. So I know we don't have like any viral symptoms, but except for the headache. And it would be really easy if it was like headache plus sneezing, and then I think like, okay, influenza and this is GBS, but it's just headache and then this hyperreflexia, lower extremity weakness, without like any bowel or like urinary incontinence. So I'm thinking we're probably like in the peripheral nervous system, and because we have like sensory signs and reflexes, I think it's nerves, not like muscle or neuromuscular junction. But we have like sensory and motor, lower extremity plus headache, and that's confusing. I don't really know how to like Venn diagram those two things together. And I know we talked before that GBS rarely presents with headache. So it's just interesting to see this, but I think we can, like, minus the headache, I think we are like in the peripheral nervous system. Plus headache, I have no idea.
Yeah, well, you're confused about the right things, and I'm confused about them as well. So your confusion is a strength here, not a weakness, no pun intended, given the chief complaint of this case, right? Because that is confusing. And many of you have heard me say this before. Sometimes when you have a whole bunch of symptoms and signs, and you're just trying to find this Venn diagram, it helps to just take one out and put it aside and play with the rest, and then see, well, now that I'm sort of more focused on this, what can I do with this other piece of information? So I'm not sure if I'm going to agree with you on the peripheral nerves, Maria. I agree there's nothing screaming upper motor neuron to us here. And gee, without that bowel and bladder, maybe we're in the peripheral nerves, but to have just pinprick and motor together and vibration and proprioception are spared, I guess you could see that. I wouldn't expect to see that with a peripheral neuropathy, right? We know that peripheral neuropathies can cause pure sensory, and some of them are going to be small fiber and be pain and temperature, and others are going to be large fiber. But if you see this pattern, again, taking the headache out for now, of weakness plus absent pinprick, and to your point before, it's going to take us time to see upper motor neuron findings here, and there's nothing in the arm. So we're really spine or below. Does that ring any bells for you or Mohammed? Just pain and temperature and weakness with spared vibration and proprioception. Does that pattern jump out? It's okay if it doesn't. In terms of a spinal cord syndrome, let me give you that clue.
I think that's anterior spinal artery syndrome. But
yeah, so the anterior cord syndrome, right? The anterolateral tracts for the spinothalamic tracts, those are anterior and lateral, and then the anterior horn cells are right there, and then the corticospinal tracts are higher, but the sort of vibration proprioception, are spared in that. So anterior cord syndrome, most commonly associated with anterior spinal artery infarct. We would have expected that to be sudden rather than worsening, but gee, that pattern of pain and temperature and weakness does fit with that, and makes me wonder about an anterior cord syndrome. Shouldn't you get bowel and bladder with that? I would think, but maybe we didn't. I just saw that chat like what someone says, but the reflexes are there. Yeah, you should lose the reflexes with that, but yeah, I don't know what to do with that, that they're still there. And so then we try to put the headache back in. If you had an anterior cord syndrome, and you thought of an anterior spinal artery infarct, and you thought of a headache, well, we know Kirtan's favorite disease is vasculitis. So headache plus a vascular event, we could wonder about vasculitis, primary CNS vasculitis. This patient would be a little bit young for that, and usually there's a lot going on by the time the patient presents. And then an acute spinal artery infarct, I would have expected to be sudden and not coming on over 4 days, although maybe it was sudden and the patient is reporting it in this way. So it looks like there's maybe an anterior cord syndrome buried in there. That plus a headache. I'm really not sure what to do with that. The other thing, no, that wouldn't work. I was thinking other spinal cord syndromes where you could get the pain and temperature and then the motor would be a syrinx, but that gets the hands first because the anterolateral tracts and the corticospinal tracts are both laminated with the hands in the middle and the legs lateral. We don't have time to get into that level of detail in my fun mnemonics for remembering that, maybe another time. So that's sort of where I am. And then if we were going to get one test here, Kirtan told us they got a lot of tests, but if you were going to get one test here, Maria, what would you get? And one test, Mohammed, what would you get? I know what I would get first. Actually, I'm not sure. Okay, you can have two tests because I want to. Yeah. What would you both get if you were?
Like, can we have imaging? Yes.
Of
like I'd ask for like an MRI of lumbar spine, and then like the second one, I'm not sure. Kieran said CSF, so I'd get CSF.
Yeah, what are you interested in, Mohammed? I agree. We want imaging of the spine. Lumbar, remember the spinal cord ends at L1, so we'd just be getting the conus and cauda there, and you can miss causes of paraplegia without T-spine. So we'll call a T and L spine MRI one test. Yeah, and then anything else you want, Mohammed?
I'll get the same MRI and I'll have a I have a side of nerve conduction study with it.
A side of nerve conduction studies. Yeah, if that MRI is completely normal, and then this is a patient where, and I remember good advice from one of my mentors when I was starting as an attending, saying, I have this case on the ward and I can't figure it out. He said, be patient. You're not going to figure it out on the first day. Maybe tomorrow morning, this patient has lost her reflexes. The arms are becoming weak. And we say, oh, this is GBS. Or maybe has some bladder retention overnight. We say, oh, we are in the cord. But yeah, if we have to decide everything right now, because it's a morning report, probably we'll image the spine. And if there's nothing there, we could think about EMG nerve conduction studies. With that headache, if that's really prominent, I know we didn't see anything to localize us to the brain here, but if the TNL spine didn't show us anything, if we're being sequential, that's where I would start. And we'll have to explain the headache later, but probably going to end up imaging the head if there's nothing there. As far as labs, I'm not sure there's anything that I would be looking for. Maria is shaking her head as a future neurologist now. The serum labs, the kidney, liver, no, thank you. I want to see the scan. Yeah, I'm with you on that one. And then Kirtan told us that there's CSF here. Again, I would want the imaging first, and then I would want to know, based on the imaging, what if something looks inflammatory, I guess we'd be getting CSF, although vascular lesions are often mistaken for inflammatory causes. And since I love time course, there's a recent paper, I think the senior author is Zalewski. I'm not sure. I always say recent, that means in the past 5 years. Recent since I was a resident, which is now 7 or 8 years ago, that actually shows that there's a lot of misdiagnosis of things called transverse myelitis and that are actually vascular conditions in the spinal cord. And the most powerful predictor is the time course of symptom onset, not the scan, not the CSF, because vascular lesions can look like transverse myelitis. If you have a stroke of the cord's not happy. There might be a couple cells and a little protein in the CSF make it look inflammatory. So I think one other point here we have to remember is that Kirtan said this patient got steroids and it didn't help. Now, steroids don't miraculously make the person go from paraplegic to walking around. So hard to know what to do with that piece. It doesn't exclude an inflammatory etiology, but that's sort of where my mind is still wondering about a vascular etiology given that symptom, although you could get an inflammatory lesion that's just proceeding from anterior to posterior. I've seen inflammatory transverse myelitis cause Brown-Séquard syndrome, just the lesion is a half moon before it becomes a full moon. And so you could see something like that. And it's certainly a young woman sort of in that age group for maybe a first presentation of MS. Still, the headache would be hard to relate to that. MS lesions are usually small. They don't cause headache. Although you can get large tumefactive MS lesions, big tumor-like lesions that are demyelinating. So I don't know. I'd like to see what the spine imaging shows. And if there's nothing there, maybe look upstairs. And if we really don't find anything, I think you're right, Mom, and maybe we're going to look at the peripheral nerves, though this doesn't feel like a peripheral process to me. Usually peripheral process, if they're going to be severe enough to affect the legs to the point of paraplegia, usually you're going to get the arms at that point. Whatever the process is affecting the nerves, right? You can get a paraparetic variant of GBS. I've never seen that, but it exists. But most of the time, by the time the patient is this weak in the legs, if it's a peripheral process, the arms will have some abnormality as well. Okay, Kirtan, I trusted you that it's going to get quick when we get to display. Tell us what you got next and give us up to, but not including the final answer so we can see if this data helps us.
Sure. I am sure the data will help and you guys are already in the right track, so no issues there. So the basic metabolic panel was fine. The CRP and ESR was normal. The EMG NCS studies were normal. TFTs, B12, HIV, HBS, AG, HCV, and syphilis serologies were negative. As for the CSF findings, the total cell count was 72, with 90% being lymphocytes. Total protein was 346 mg per dl, which is very, very high. And the glucose and opening pressure was normal. And there was no evidence of oligochronal bands. Now, as for the imaging findings, the MRI of the brain revealed focal, solitary, 35 by 20 millimeter size, altered signal intensity lesion involving the splenium of the corpus callosum on the left side, which shows faint peripheral irregular rim enhancement, and the lesion shows a central non-enhancing area with hypointensity on T1 and hyperintensity on T2 and flare sequences, So basically, to simplify, the splenium of the corpus callosum was involved, a part of the body of corpus callosum was involved, and parafalsa and parieto-occipital lobe was involved. As for the spinal cord imaging, there was long segment, intramedullary, multifocal, T2 stir hyperintense changes within the dorsolumbar cord, and the predominant lesion was seen extending from the D1 to D6 level, and another lesion was seen at D8 to D9 and D10 to D12 level. And this is all you get. And I apologize for not getting to the imaging studies because of the COVID pandemic. It was so hard to get hold of those images, but I guess these imagings will help you.
Okay, so that was fantastic. So there's a single lesion in the corpus callosum that has various signal characteristics you told us about, and then there's multifocal small lesions in the spinal cord. Is that right? Just to make sure we have the high level. And then elevated protein, elevated lymphocytic pleocytosis, 72 and 340 something for cells and protein, normal glucose and opening pressure, and every serological test for every infection, metabolic thing was normal. Is that the fair summary here to set Mohammed and Maria up for success? Okay, I forget who's first. We've been going back and forth. What would you wager as a final diagnosis here, Mohammed, Maria, and then I'll tell you what I think here. Yeah.
So I think we sort of went from spine to brain, back to spine, and then now we're in both. So now it makes sense that we have both the headache and so Occam's razor doesn't always work, and that's why you have Hickman's dictum. And you have two lesions actually that could have explained like her headache and her weakness. So now it like at least makes sense. I don't know what this is, what she has, but at least now it makes sense her symptoms. Her multiple like nodules. I wonder if so let's go for a bit systematically. The LP showed like elevated, I think, cells and predominantly lymphocytes with a high protein and the normal glucose. So that goes towards a viral illness. A viral illness causing these kinds of lesions is difficult, and I can't really think of anything that would cause a central 35 by 20 lesion and a hypodensity as well. Tuberculosis, I think, causes a low glucose. I'm not sure if it can present with a normal glucose. So I'm kind of lost as to what does she exactly have. I wonder if this could be like a demyelinating syndrome with a multiple, like something like I wondered, like I forgot honestly the variants of MS or the demyelinating. I remember there was NMS, but she doesn't really have any. Oh, actually, it could be NMS, neuromyelitis optica, but she doesn't have any optica. That's why, yeah, that's what I was missing. So I'm not sure. I'm sort of in the realm of like demyelinating / inflammatory or infectious, although like most of her serologies were negative. TB could still be on the table if it can present with like a low glucose, but I doubt, honestly. She's like, it sounds like it's way too sick for TB to just be in the spine without affecting like other organs at this point. So I'm not sure.
Great. Yeah, great thoughts. So coming back to our original hypothesis, right? This is acute, but not sudden, bilateral lower extremity weakness in a young woman. When you have that problem, we're leaving out the headache for now, that problem representation, you're sort of in the infectious or inflammatory category. We briefly invoked sort of rare vascular things. So that's certainly a very good hypothesis. Maria, where is your compass pointing here?
I don't want to wager on anything because I don't know. You know, for me, like the ultimate Venn diagram was like lymphocytic pleocytosis and a lot of ring enhancing lesions everywhere, corpus callosum and spine. And when I put those two together, I don't know, because lymphocytic pleocytosis can be like autoimmune, infectious. It can be metastatic, and then when we put that, like ring enhancing lesions can also be autoimmune, infectious, hemorrhagic. metastatic. I'm not sure. I agree with Mohammed. Like I was thinking about TB first, but I expect like lower glucose, and I feel like she's not like immunosuppressed to have this sort of TB or neurocysticercosis, or I'm not sure like what other ring-enhancing lesions are there, but or like she hasn't had like systemic symptoms to be thinking of like multiple abscesses. So I'm not sure. I have no idea.
Yeah, that's a tough one. Kirtan, let me clarify one thing. Did you say that there were any long segment? I'm just reading the report here. Maybe you said this and I missed it. For the spinal cord, I thought you said there were small lesions like a D1 to D2, D8 to D9. Was there also a long lesion, or did I?
Yes. Yes, sure. So actually the hyperintense changes were there in the dorsal lumbar cord all throughout. And the predominant lesion was from D1 to D7. So it was very long segment.
Long segment. Yeah.
And then there are a few other lesions, D8 to D9, D10 to D12,
Yeah.
some in the lumbar. That's all. Got
it. Great. So yeah, we have, two things here. We have the imaging, right? And we have the spinal fluid, which should help us get pretty close to the diagnosis. So imaging, right? Both of you picked up on whatever we want to say about the splenium of the corpus callosum and the spinal cord. There are multiple lesions, right? Which makes us think about diseases with the word multiple in them, like multiple sclerosis. And Mohammed reminded us that multiple sclerosis has some friends, like neuromyelitis optica. And neuromyelitis optica was a name for what was thought to be a variant of MS, so-called spinal variant, or I think called spinal, maybe I'm wrong about that, also called Devick's disease. But then despite years and years of trying to find a biomarker for MS, for NMO, they found a biomarker, the aquaporin 4 antibody. And once you have a biomarker, anyone with that biomarker has the disease, and the syndrome has really expanded so that they now call it NMO spectrum disorder, because to your point, Mohammed, not all patients have the M and not all patients have the O. Some just have the N, the neuro. There's patients who can present with area postrema syndrome, nausea, vomiting, hiccups. They don't have any spinal cord or eye findings. There's patients that can present with brain lesions that don't quite look like the lesions of MS. So when you hear longitudinally extensive transverse myelitis, something more than 3 levels of the cord, that's why I was particularly interested in that, something from D1 to D7. MS doesn't usually do that. Usually it's tiny, small lesions, just like you have in the brain, or in the spinal cord, and it doesn't go more than 3 levels. It can do, but that's pretty uncommon. There is a whole differential diagnosis for longitudinally extensive transverse myelitis. Sarcoid can do it, Behçet's can do it, radiation-induced myelopathy can do it. B12 deficiency is not a myelitis, but it can cause a longitudinal lesion in the dorsal columns. But when you hear longitudinally extensive transverse myelitis, NMO should pop up on your list. Now, this patient doesn't have O, they have M, and they have this splenium lesion, which is just white matter that's pretty non-specific. NMO likes the areas around the ventricles. That's where there's a lot of aquaporin antibodies around the 4th, around the 3rd. So it sort of has an inflammatory feel to it by the time course in the imaging. And then what do we do with that LP? That's a lot of cells. So Maria, and Mohammed both pointed out, if you just saw that LP and said 72 cells, protein 346, that sounds like an infection, right? That's a pretty high protein. That's a pretty high cell count. I mean, if someone looked like they had Guillain-Barré syndrome, but this patient obviously doesn't anymore with that scan, and you saw that, you'd say, that's a lot of cells for, I'm okay with a few, but that's a lot of cells. And if it was GBS, again, I'm going off on a tangent, you would worry about HIV seroconversion causing a polyradiculopathy or Lyme disease in an endemic area. But if you saw that pattern in meningitis, you'd say that looks kind of viral, right? And then what do we do with it here? Well, NMO and its new friend anti-MOG, which presents a little differently than this, but another sort of cousin of MS, although these are diseases that rapidly got their biomarkers, and MS is still waiting for its biomarker. You can have a pretty reasonable lymphocytic pleocytosis. You can have a reasonably high protein. That's a pretty high protein, but maybe the spinal cord is so inflamed that it's causing what's called a spinal block, and you don't have great circulation of CSF, and the protein goes high. And the lack of oligoclonal bands, you might say, well, then, gee, it shouldn't be inflammatory if there's no oligoclonal bands. They're very common in MS. They're not specific. You can see them in infections and other inflammatory conditions, but they're much less common in NMO, actually. So for me, if we were to put this all together, Still don't know what to do with that headache, but this patient has a longitudinally extensive transverse myelitis, a lymphocytic pleocytosis, no oligoclonal bands, and a brain lesion that doesn't really look like it fits into any other clear pattern. There's lots of things that can happen in the splenium. That's another story. Then I would probably call this NMO. And why does she have a headache? I mean, that lesion is not that big to cause a headache. So I still don't know what to do with the headache, even with all this data, although it clued us into the fact that we needed to look at the brain, not just the spine. So I think I would agree with both of you that this is inflammatory, and I'd be willing to say this is NMO and that the last test is an aquaporin for antibody, but we know Kirtan always has surprises for us. So let's see what they found here.
Yes. So given the multifocal neurologic deficits with imaging findings consistent with demyelinating etiology, it was very fascinating. So I just wanted to briefly mention here that few years back, one amazing paper was published known as Brain Eye Ear Syndromes. It was written by Dr. Todd Hardy from Sydney, and it is an amazing paper which describes how all the neuroinflammatory disorders can present with characteristic imaging findings. So whenever we have involvement of corpus callosum, during that time, I created a mnemonic in my mind by reading that paper that everything which has got S in it, so like multiple sclerosis, which S, sarcoidosis, Suzak syndrome, Sjogren's syndrome, all of them can do that. And all the toxic leukoencephalopathies can do it. And in this case, since the patient had headache and extremely high protein levels, I was wondering what if there is a component of aseptic meningitis, because aseptic meningitis doesn't always present with meningismus and all the signs that you anticipate. And maybe they were present, but because of the all other things, they were not the chief concern. So we thought that let's order those serologies. So we ordered those serologies and the serum ACE level was normal, but the ANA was positive and the Rho and La antibodies were off the chart. So they were like 100 and 105 international units per ml, which are more than 10 times the upper limit of normal. So it was consistent with Sjogren's involvement of the brain, but we did order NMO2 and the aquaporin 4 antibodies usually take a time to come. So Rho and La came just the next day and the aquaporin 4 took a long time. And after 2 weeks, it came back and it was positive. And I guess in our previous VMR, you mentioned that aquaporin 4 antibodies and NMO can exist with Sjogren, with SLE, with P. encapsulated vasculitis, with myasthenia gravis, and with autoimmune thyroiditis in 40% of the cases. So we know that overlap is present, but given the characteristic imaging findings and the evidence of headache, it was considered that the head part was mostly due to Sjogren's and the spine part was mostly due to NMO. And there is definitely overlap here and there, but it was consistent with the fact that Sjogren's was contributing. And in fact, after that test was positive, we did the Skirmus test and it was positive, which means it was not just Rho was positive just for no reason. It was positive because the patient actually had primary Sjogren's. And then as for the treatment, we gave the patient IV methylprednisolone and the plasma exchange. But as is the case, sometimes NMO doesn't improve with all those things. So we have to give immunomodulatory agents. So as soon as we started the patient on rituximab, she started to improve. Then we even added the azathioprine. And last time when I checked, so it was just a few weeks back when I called the patient, and the patient was actually able to walk unsupported. So she told me that she has gained like 60 to 70% of the weakness, but not entirely. But I hope that she improves. So this was a nice case, and all thanks to that amazing paper. I even shared that paper with Maria and our all student team members just a few days back.
Yeah, great case, Kirtan. We should have known that it couldn't possibly be just one diagnosis if it's a case from Kirtan. So the neurology here, great job, Maria and Mohammed. You got this to inflammatory, and Mohammed, you got this to NMO. It's interesting what you say. For NMO by itself, I wouldn't go looking for Sjogren's if the patient didn't have dry eyes, dry mouth, etc. However, if the patient has Sjogren's or lupus and develops longitudinally extensive transverse myelitis, something like 70 to 80% of those patients actually have NMO as the cause of their myelitis. So there's a whole, people know I love neurology of, fill in the blank, and there's a neurology of Sjogren's, so there's lots of things Sjogren's can do, so that's why I'm talking three things at the same time, but two syndromes you can see that can be the presenting features before dry eyes, before dry mouth, is a sensory ganglionopathy or neuronopathy, which presents with a sensory ataxia. There's a whole differential for that, but Sjogren's is on it, and NMO, longitudinally extensive transverse myelitis. So in patients who have a longitudinally extensive transverse myelitis and you find NMO by itself, like I said, probably would have stopped there and treated it as you did. And it's interesting that you thought because the brain stuff didn't really fit, you went looking for Sjogren's and did the Schirmer's test, which is fascinating. But yeah, for people who are on the medicine side, following your Sjogren's patient, following your lupus patient, they develop myelitis. A large proportion of those patients actually have coexistent NMO. So once you have an autoimmune predisposition, then these things can run together. So when you first told us it was just Sjogren's, I thought, oh my goodness, wow, you picked Sjogren's out here without any dry eyes, any dry mouth. That's amazing. But this, this presentation of NMO and Sjogren's together has been described. And the very first review article I wrote as a resident with one of my mentors, when I saw a patient with Sjogren's presenting with what was ultimately probably a ganglionopathy, but very severe to the point the patient couldn't move, we learned about this. And we can send out a paper called The Neurology of Sjogren's and the Rheumatology of Neuropathy and Myelitis, or something like that, in Practical Neurology from about 10 years ago. So amazing case, Kirtan, as always, and we will learn for next time when we wager our final diagnosis in a case from Kirtan, we actually have to always have two diagnoses, because last time it was NMO and NMDA receptor encephalitis together, and this time it was NMO and Sjogren's together. Brilliant case, Kirtan, brilliant case, Maria and Mohammed. And I think Valeria or Gabby has some teaching points for us. Fantastic discussion and fantastic presentation as always.
And just so lastly, I wanted to mention that as you rightly told that I like vasculitis. So actually the Sjogren's can call all of this because of immune-mediated vasculopathy, because Sjogren's can actually cause small vessel vasculitis, and that affects all these things. So indeed it was a case of immune-mediated vasculopathy along with NMOSD. So I'm glad that it was indeed vasculopathy.
Amazing case, Kirtan. So today I'm doing teaching points. And we started with the chief concern, which was bilateral lower extremity paresis. And the first point that Maria mentioned was to differentiate paresis from true weakness, or if it's true weakness, from something like asthenia or fatigue, or something affecting other sides of the neurological exam, like ataxia or a sensory change with a motor compromise of the patient. And then she pointed out the fact that we could approach this with what Aaron always reminds us, thinking about localization and time course. And so thinking just from the cortex, something like meningioma that could affect both the homunculus bilaterally, then going down to the corona radiata, the spinal cord, something affecting the roots, such as Callosum syndrome, and then the peripheral nerves, neuromuscular junction, and the muscle itself. And then she also mentioned that as it is bilateral lower extremity paresis and something affecting the cortex like a stroke or a meningioma could be rarer than something affecting the spine or the peripheral roots or nerves. And then Mohammed teaches us about the time course in which we could differentiate causes of hyperacute paresis like a stroke or trauma, and causes of acute onset paresis like metabolic causes, transverse or inflammatory myelitis, abscesses in case of infectious etiologies, and Guillain-Barré syndrome. And then subacute etiologies such as a mass effect like a tumor, malignancy, or a tuberculoma, and chronic etiologies such as degenerative like MS, spondylitis, HSP, and viruses like HTLV1. And then the patient surprisingly had a headache, which was occipital. And so that made us think of something that was looking more like peripheral, like a spine or like a nerve, or root. But then the headache made us think of something affecting the brain. And so Mohammed pointed out that an occipital headache made him think of Press syndrome, asking for the past medical history of hypertension or the use of steroids that could be a trigger for this syndrome. And then the time course made us think that something could be affecting both the spine and the brain. Etiologies such as infections like tuberculosis that can have this diffuse compromise, AV fistula that is also a cause that could be worsened by steroid use, and RCVS. And then the fact that the patient had a headache and bilateral paresis. Mohammed mentioned hemiplegic migraine, that he wondered if could have this also this paraplegic presentation, and asking the patient if she had a history of headaches, tuberculosis, as I mentioned, and inflammatory post-infectious encephalitis, such as it was in this case. And Aaron also mentioned venous sinus thrombosis affecting like the crus-cerebral, the mid bilateral cortex. And then a lot of questions about who is the patient. I saw in the chat that someone mentioned like this was a middle-aged woman, and just the thought of the headache that was kind of confusing. Could this be idiopathic intracranial hypertension? The immune status, thinking about exposures such as TB. And then Maria took us through looking for clues in the physical exam, looking for systemic symptoms that could point out to infections, such as nasal neck rigidity, and differentiating upper versus lower motor neuron syndromes. And she made the point that maybe it was too early to tell or to differentiate between the two. And then the exam showed us that the patient had paresis and a very specific loss of sensation, which was only pain and temperature. And so Aaron pointed out that this was very, very specific for anterior cord syndrome. And the fact that the patient also had headache made us think, okay, something is affecting the spine, but would also be affecting the brain. So maybe multiple infarcts, and knowing that Kirtan loves vasculitis, that could be a possibility. And then Aaron gave us this pearl that inflammatory spine conditions that can have an acute onset can have very similar imaging to vascular etiologies, but that have hyperacute onset. And so we can use the tempo to differentiate between the two. And then the LP showed us that the patient had lymphocytic pleocytosis, and this is a differential that we saw in a previous case that can be from infectious and non-infectious causes, in which the non-infectious, we can prioritize autoimmune and malignancy. And Kirtan gave us a good pearl that was a mnemonic that autoimmune encephalitis, all the systemic causes of it can have an S on it. And so Sjogren, like it was in this case, sarcoid, Sussex syndrome, and SLE, for example. And then, well, finally, the antibody showed us that it was Sjogren's, but 60 to 70% of encephalitis in Sjogren's syndrome are caused by NMO. And so these two conditions can coexist as it was in this case. And thank you. This was an
amazing summary, Valeria. So thank you so much, Kirtan, for bringing us this case. Keep bringing us more cases. And Mohammed and Maria, great to have return discussants. Hopefully you saw how much fun they were having and how much we were all learning together and how much we were all sharing our own confusion about how to do this and how to think through this case. So please use that as encouragement to join as a discussant next time. And Valeria, thanks so much for your brilliant teaching points. All right, everyone. Thank you again. Have a nice long weekend for people celebrating July 4th in the United States, and everyone else. Have a nice, I know that's still a far way away, but for us, it's rare to get days off. So we're looking forward to that next Monday. And for everyone else, have a nice day, week, and we'll see you next Tuesday. Canada Day also, that's right.